Lakeside is pleased to sponsor this exciting broadcast featuring Dr. Sandra Bloom and Sarah Yanosy on Voice America.
Welcome to Creating Presence with your hosts, Dr. Sandra Bloom and Sarah Yanosy. Over the next hour, you'll learn about the processes that steer our hearts and minds and how to improve our collective social health.
Welcome to Creating Presence. I'm Dr. Sandra Bloom, and I'm here with my co-host, Sarah Yanosy. Sarah and I have developed an organizational intervention to help organizations integrate trauma-informed practice. And we use the word presence as an acronym for partnership and power, reverence and restoration, emotional wisdom and empathy, safety and social responsibility, embodiment and enactment, nature and nurture, culture and complexity, and emergence and evolution. Today, we're going to look at the R in the acronym of reverence and restoration. And we're going to take a deeper dive into this topic with a social health focus on the challenges of healthcare and mental health care service delivery.
Yeah, a lot of the organizations that are using Creating Presence are healthcare and mental health care organizations. So I have a lot of experience now, not just in working in mental health, but also with organizations that are doing the same and trying to use trauma-informed practices. And there are a lot of things I'm finding from my own experience and also in coaching that are sort of universal issues in trauma-informed practice with organizations. And one of the things that really comes up a lot is this fight or flight reaction that systems have. So the same way that individuals who've experienced trauma, adversity, or chronic stress respond with fight or flight, so do the organizations themselves. And that results in a lot of problems with patient care. And we see that through re traumatizing inadvertently rather than restoring. So, a lot of the work that we're doing has been on helping them recognize the risks around confusing accountability with punishment. So, our work in reverence and restoration is about using restorative approaches. We've been doing a lot of work around performance reviews, really helping to identify what's important to staff members who are being evaluated, what's important to them about the work, how do we help them feel respected, and also how people respond to incidents, critical incidents. And the reason that those things are so important in our work is that organizations can really, under that fight or flight response, start to focus on survival instead of on people. So it looks like focusing more on money as the highest priority, being less compassionate or understanding, or staff feeling like they're replaceable parts in one cog in a wheel.
And that often starts at the top. That's what I've seen, right? And as it happens more and more, the you know what flows downhill, right? So decisions are made somewhere in the hierarchy above the actual caregivers, but they don't have any input into those decisions, even when it profoundly affects the work that they're doing. And people respond. Some people respond by just feeling like it's inevitable and there's nothing they can do. And other people get really angry and can take it out on each other or on the clients. And some people speak up, and that puts them at risk. They can get into trouble in some institutions, particularly those that where there's a sense of institutional betrayal. A couple of weeks ago, we talked about institutional courage and how important that is, that it has to be safe to speak up about your concerns.
So, we're going to expand this conversation about healthcare and mental health care with our guests, who happen to be two people who are shaping trauma informed healthcare, mental health care, and addiction services. And they are going to share their own perspectives on what has happened and also what needs to change in these systems. Dr. Maggie Bennington-Davis is the Senior Medical Director for HealthShare Oregon and the co-author with Tim Murphy of Restraint and Seclusion, the model for eliminating their use in healthcare. Welcome, Maggie.
Hi,
Great to have you.
it's great to be here.
And our other guest is Tim Murphy, who's also with us. After many years in mental health services, Tim is the founder and the CEO of Bridgeway Recovery Services in Salem, Oregon. So welcome, Tim.
Good morning. Welcome, Sandy. Nice to see you and Sarah and Maggie. This will be fun to have this discussion.
Well, you both have spent a long time in your careers in mental health and social services. And I first knew you many years ago when you were running together a psychiatric inpatient unit. And you were both working on making that inpatient program trauma informed before there was even a word for it. That word didn't even exist yet. So from your perspective now, how are we doing in terms of trauma-informed care and providing reverence and restoration to the clients that are under our care? Maggie, you want to take that for a minute?
Yeah, it's first of all, thank you for the invitation to be part of this discussion. It's really great to be here. And, looking back at that time, and Sandy, I noticed how you really stressed the long time you've been doing this work. And it's true, it's going into like multiple decades at this point. And, when I look back at that time, I'm so proud of the work that we did back then, and those lessons really from you, Sandy, stay with me in everything I've done since, all the jobs I've had since, and all the initiatives that I've been engaged in, and both in work and in life, I would say. And, I do think things are better. There's a better awareness of the effects of trauma generally, whether it be in our schools or in healthcare, certainly in mental health care, but also of how systems, especially mental health treatment systems, do indeed have the potential to create trauma, sometimes by their very nature, like when they're involuntary. And I think, seclusion and restraint and involuntary medication are the most blatant examples, but there are 100 other examples too, taking people's personal property, preventing them from visiting with their loved ones, having rigid schedules and consequences if rules aren't followed, and then probably 1,000 more subtle ones, treatment team meetings without the person themselves present, the language used to describe people and their symptoms. And I think there's a greater awareness across the spectrum in mental health treatment about those things. So I'd say things are better, but not cured. And I also see replication of trauma in non-mental health settings, such as emergency rooms and hospitals themselves, and even in primary care. And in some ways, I think behavioral health is doing better than the rest of healthcare because of its knowledge of trauma. And non-trauma informed health services result in people, especially people of color, people who have immigrated, people who use a language other than English, not seeking or accessing care or receiving good care, which in turn results in these tremendous disparities in health outcomes. At least that's what we're seeing in our data at HealthShare. The people with the most health conditions that aren't getting care are the people most disenfranchised from a system that doesn't make it easy or welcoming. And I think that comes from structural inequities, which have spawned traumatic experiences for centuries. So I think we writ large in healthcare are just starting to look at trauma-informed health systems, on a larger scale. But Tim, what's your recollection of way back when?
Turn
Turn of the
Thank
century,
you.
yeah.
Thank you. And I too, it's a pleasure and honor to be with you three in this discussion. And yeah, it goes back to, I think, 2001 when Sandy, you first came and visited us out here in Oregon and looked at our inpatient unit, which was a very traditional unit. And we weren't doing anything outside of what was considered the norm at that time. But what we were doing was not really in line with current thinking. And it's true that there wasn't a trauma-informed care concept at that time, but there was an awareness of trauma. And I think, Sandy, you really brought us to think about that. And so it's been a slow slog. Both Maggie and I spent several years at that hospital. I think we left in 2005 and have gone on to other organizations. In that time, the term trauma-informed care emerged. We're here, we see it everywhere. So I think in that sense, there's been a significant cultural improvement in lots of venues. Maggie went through a couple that were non-medical settings, but also we're seeing it in schools. I have counselors on every school in Salem Kaiser School District that are talking about trauma-informed care with students and also with teachers. We're working with organizations to set up environments of care that reflect non-coercive environments that are more welcoming and supportive. In the last, about a year and a half ago, I opened a new clinic completely designed with the principles of trauma-informed care involved in it, so that the people, not only for the people that come there for service, but also the employees that work in that environment. And I think those things start to set the tone and start to set the feeling that there's hope here, there's help here, and it's safe to come here. And so based on that work that we did with you, Sandy, I'm with Maggie. Everything I do, your voice sometimes is in the back of my head. Sometimes that's a good voice. Sometimes that makes me work harder. But I appreciate it.
Thanks, Tim.
We really covered, I think, a wide range in what you both have said, really sort of highlighting the micro experiences, like restraint and seclusion as, part of replicating trauma experiences for individual patients, and then really understanding more at the macro level the systems of oppression that impact care. What kinds of things are you doing to change how care is getting delivered, and what are you seeing as a result?
That's a great question, Sarah. One thing you want, Sandy, or you mentioned something about organizations and the cost of healthcare. One thing we learned was to really be good at this work. It took a bigger and different type of investment with staffing, with environment of care, that hospital systems sometimes don't understand why you're making that investment. And I think in our history, we saw that play out for us, where we increased the cost of care, but really reduced the coercive environment, really improved the patient experience, really improved patient outcomes. And you need to have your full executive organizational support in order to understand that. And I think one of the mistakes we might have made early on is we just launched our own little process without really educating why we were doing that. Now, when we started to get positive results, that really helped. When we saw lengths of stay shorten, when we saw outcomes get better, when we saw the use of medications needed by patients reduce, when the numbers of seclusion and restraint came down and eventually just totally went away, we had some, bragging rights as far as that this was successful, and it really encourages me in the future work once we left the hospital, was to really have everybody on board when you launch an initiative and understand what you're going to do and why you're going to do it. and that patient's voice and patient care needs to be integral into the work that we're doing.
I just really appreciate how, Sandy, at the get-go, you emphasized trauma-informed care kind of throughout, not just in direct care, but also throughout the hierarchies of our systems. And so I'd say that's where I spend a lot of my time these days, is kind of climbing through that hierarchy and trying to make sure that it's consistent. The tenets of trauma-informed care are consistent.
Yeah.
Thanks, Maggie and Tim. And thank you for listening to Creating Presence. Coming up after the break, we'll continue our discussion with Dr. Maggie Bennington-Davis and Tim Murphy. We'll be right back after this message.
If you would like your organization to be aligned in its values, practices, and skills to be trauma-informed, trauma-responsive, and trauma-resilient, Creating Presence is the program you are looking for. The Creating Presence model is an online and coach certification program authored by internationally renowned Dr. Sandra Bloom. This program is designed to help your organization become certified as a safe and value-aligned place for both your staff and clients. Creating Presence is managed by Lakeside, the host of this broadcast. For more information as to how your organization can create presence, go to creatingpresence.net. Lakeside, your resource for trauma-responsive care.
Welcome back to Creating Presence. Sandy, Sarah, and their guests will discuss strategies and innovative practices for restoring our collective social health.
Welcome back to Creating Presence. I'm Dr. Sandra Bloom, and I'm here with my co-host, Sarah Yanosy, and we're talking with our guests, Dr. Maggie Bennington-Davis and Tim Murphy, about the challenges of caregiving and how we can move toward a caregiving system that focuses more on reverence, respect, and restoration. So, Mags, you've been in management positions for a long time in a lot of different systems and institutions. So, can you describe what, at this point, your ideas are around what good care really looks like?
Yeah, thanks, Sandy. I'm not sure I'm going to get the exact answer that you're looking for, because I keep thinking of that mantra that, comes in various forms: physician, heal thyself, put your oxygen mask on yourself first before assisting others. The best care comes from those who have had the best care. Loved people love people. It took Tim and me some time to understand that when we were first working in the hospital 20 some years ago. We wanted to make services healing instead of coercive. And that's when we first engaged you, Sandy, to help us. Creating Sanctuary had just come out a couple of years before the adverse childhood experience study was out and being studied. I was a young leader and I was really eager to dive right in and just get staff to start doing things right, just because we said so. And they kept asking, what about us? Which, honestly, I ignored. And then I eventually got irritated until eventually it became impossible to ignore it. And with coaching from Sandy, we reversed course and concentrated on staff first. And eventually that effort really paid off big time. And now in my current job, where HealthShare is a coordinated care organization with 460,000 Medicaid members, we have over 20,000 providers of all types that we contract with in our network. And I'm seeing unprecedented rates of burnout and cynicism and moral injury. It's really kind of terrifying. And I think with the tremendous commercialization and monetization and bureaucracy of healthcare, providers have been asked to do more and more with less and less time and less appreciation. And then the pandemic era, I think, spawned a time of anger and division around masks and vaccinations and isolation. And medical providers felt disenfranchised even from their own patients, as well as their own profession. And so when I think about good care, it's a lot like what Tim said a few minutes ago about the clinic that he's developing. It's hard for me to imagine good care until we get our arms around that, having safety and deep respect that providers used to have for their profession and that others of us had for them. I listened to Dawn Isaac last week on this podcast, and here's a direct quote from her. People want to work where they feel safe, listened to, and effective. And when that's present, then good care can flow from that. So I think good care has to start with that, us getting back to that kind of central tenet of that kind of deep respect and regard that we have for our work and for each other.
I really appreciate, Maggie, your comments because they're a good reminder of the importance of reverence, not just for our patients, but also for our staff and the work itself. Often the reimbursement structures, the barriers to care, they really create experiences of discouragement for staff and for systems. And so I'm curious to hear from both you and Tim about what it might look like to really connect with the concepts of reverence and restoration in doing this work in healthcare and in mental health.
Well, let me add something. So about 15 years ago, Maggie and I were invited to go to a conference put on by consumers of mental health system services. It was put on by peers, and we were sort of the represented a hospital, and we weren't sure we were going to be welcome there. But I was introduced to that phrase that we're all very used to now: "Nothing about us without us." You could buy a T-shirt there. And this was really talking to us because we would, at that time, do, as Maggie said earlier, do treatment planning without the patient necessarily involved, without the voice of the person that was the services were designed for. And so we sort of adopted that and thought about it as far as patient care, but also became really part of our staff message as well. And so with Sandy's introduction of community meeting to us, I've found that that's such a valuable piece in our various settings. So in our residential settings, in our outpatient settings, in our inpatient settings, starting each day with a community meeting where the people that work there and the people receiving services sit together, common ground, nobody standing, no clipboards, no keys, just, hey, we've got some time to share together and we're in this together. And that started to change the tenor of the situation. We saw less conflict in our residential homes when the staff were really open about, I'm here to work and we're going to share this space together. About 6 years ago, in talking with patients that had access to primary care but wouldn't go, these are folks that were struggling with symptoms of addiction, symptoms of mental illness. They didn't feel welcomed in their primary care offices in the community. They didn't feel that they were wanted there. And frankly, they weren't. They were treated poorly. So we were the first addictions clinic that opened up a primary care clinic inside our addictions clinic. So we hired a nurse practitioner at first and then a physician's assistant. We started out 2 half days, and it had just exploded in need, in use. So now we're seeing 1,000 patients every month at Bridgeway. And we have a significant load in our primary care because and Maggie gave me this, we turned our exam rooms, our medical exam rooms, into listening rooms. And so people go in, it looks like an exam room, but we've taught our staff and our patients, our clients, that this is a safe place where you can talk and we're going to listen to what you have to say. And that speaks to the reverence part, I think, Sarah, that you were asking for.
Yes.
And it's simple things like that, language you use, being open, being invitational, that makes such a big difference. And they don't cost anything.
Right.
Right? You know, it's kindness and niceness and having an open heart and a loving attitude that creates a space where, you know, that's where healing occurs.
Well, and in that example, it really strikes me that by demonstrating reverence for your patients and that use of language, you really open the door for an experience of restoration of trust, restoration of relationships. What about you, Maggie?
You know, for some reason, I'm thinking of, and I'm sure it's kind of riffing off of Tim's stories. I'm thinking of an initiative that Hellshare started now about 10 years ago called Project Nurture. And, you know, sometimes pregnant women with substance use issues are sort of shunned by all systems. So often, you know, maternity providers are scared of a woman with substance use, and often substance use providers are reluctant to engage in treatment with a woman who is pregnant. And then, of course, the Department of Human Services, well, you know, all those providers are reporters to the mandatory reporters. And so the person runs the risk of, you know, having to give up their child. And so we realized that the very most, you know, vulnerable and in need people didn't have easy access to care, certainly welcoming access. So we created a program exactly designed for them. And it almost starts with the people who want to work with that population, you know, and have a real passion for it. And then we partnered up with DHS. So you know, the babies wouldn't get taken, and put together a whole trauma-informed program that, you know, includes peers and doulas and very willing, passionate providers and group experiences and loving environments, as Tim said, and some sort of reassurance that there was going to be support before, during, and after birth, parenting support afterwards. We're even looking at adding housing. You know, no child should be born into houselessness. And that program is so, when I think of the word restoration, I mean, everything about that program is beautiful. The providers don't have the terrible ethical and moral dilemma. The workers in the program see frankly miracles every single day. There are far fewer babies in the foster child system. The costs are way lower because the babies aren't in the neonatal intensive care unit anymore. I mean, it's just a win, 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 win everywhere you look. And so I think as we get smarter about programs like that, that are, you know, looking at how do we disenfranchise people and how can we flip that on its head and engage people in that, you know, loving and passionate way, that, you know, we start to make progress. And, you know, we're doing that in other programs as well, just starting that, but it's, boy, it's sure slow going, and it really is kind of program by program by program.
Because it requires such a shift in the paradigm that we've all been, you know, functioning against for so long. Given what we've been talking about, what are the lessons learned from this collective trauma that we've been through in terms of the pandemic? What did you experience in terms of how the challenges and the victories as a result of the pandemic?
Wow. I think the lessons we're still learning. I don't think we know yet. I don't think we know how much damage we did the way the pandemic was managed. The alienation, the separation, the fear, really, and it may have been all necessary, but it still had a damage potential to it. One of the things that in my clinic and what I saw from my colleagues in the community, people learned to move quickly to provide services. So within 48 hours, we had to close all of our outpatient clinics and turn all of our inpatient counselors into remote therapists, We gave them all iPads and headphones and said, go home, call people, and do whatever you can do. And so we did that work. And we also saw slowly the people that we were serving respond. And so, and one of the things we learned was that some folks that weren't coming into the clinic that often because they live an hour away or an hour and a half away, well, all of a sudden we were seeing them more frequently because we were connecting with them remotely. And so there's some of that piece we want to keep. There's some connections that we made that were good. I think we've come out of the fog of the fear, and I'm worried. I'm really worried about the kids. To be really clear, I think we did some damage by keeping kids out of school for 18 months. And we're seeing that now with increase in substance abuse, increase with absenteeism. So we've built some teams to really reach out and try to help the schools bring kids back in.
Mm, mm.
Tim,
There-
as you're describing these, issues that have come up over the pandemic, it strikes me that we're really talking about kind of overlapping systems and overlapping structures and needs. And it connects me back to what you were saying, Maggie, about creating the program for addiction treatment and pregnant women, and the efforts that you were able to make to build those bridges around different care systems. And I'm curious, to both of you, how have you experienced that? I mean, I think defining good care includes, at least in what I've heard from you, these collaborations. How do you start? How do you start to make that happen in order to create these really amazing, innovative programs?
Yeah, I love that question. Coordinated care organizations, which I think is a model unique to Oregon, is really rests exactly on that. And even at their inception, contractually, we're obligated to reach outside the traditional healthcare system and hold hands with early learning hubs and schools and community-based organizations, social organizations, and so forth. Um, so I think the pandemic forced us to do that, really forced the walls of the traditional medical system to come tumbling down, because the people that we weren't getting to are the people who were, didn't touch the healthcare system and were disenfranchised from the system and wouldn't, touch it with a 10-foot pole. And so in order to get to those folks, we had to work through churches and community-based organizations, social organizations, immigrant offices, preschools, that kind of thing. And so I think that set us, we thought we were working across the walls of medicine before the pandemic, and then we found out how much more we had to do. So, we started holding hands with those other organizations, and now we're determined not to let go. So one of the interesting things Oregon is about to do is make housing a Medicaid benefit for certain populations, so paid for out of Medicaid. And, medicine doesn't know anything about housing. And so to figure out how to kind of get into that system, the housing system, at least where we are in the metro area of Portland, Oregon, it's a huge undertaking. And we just, every day, we discover how much we don't know, we didn't know, we don't know about that system, which has its own entire, ethos and culture and so forth. And frankly, is at its roots a lot more trauma informed than the medical system. So that's been sort of a joy. But I think the pandemic helped us figure out those things that we don't know, that we need to kind of get more humble and approach each other in a new and different way.
Yeah, sort of I'm thinking about having reverence for the work of others and kind of connecting it in that way too. Tim, any
Mhm.
final thoughts?
I'll be really quick. Maggie mentioned the coordinated care organizations, and one of the things that we learned through the pandemic was to look for services that were needed that weren't Medicaid covered, and go to these organizations like Maggie's and others in the state and say, we want to provide services for family members, even when the identified patient isn't willing to participate. So we want to work with the kids, the spouse, and the family members that traditionally Medicaid wouldn't pay for. And we've been given the ability to do that. So
Wow.
we've now started groups for folks. And you know what happens when the spouses come in and the kids come in and that patient doesn't want to participate? They show up.
Sure. You bet.
So we're doing some innovative things in Oregon. I'm really proud to be part of it.
Great.
Yeah,
Thank
you're
you so
lucky.
much. We want to thank you for listening to Creating Presence. We just heard from Dr. Maggie Bennington-Davis and Tim Murphy. Coming up after the break, we'll talk with Dr. Caroline Finkel and Dr. Eli Muir about Charlie Health, an innovative young company. We'll be right back.
If you are a professional who would like to know more about how to provide care for individuals who have experienced trauma and adversity, Lakeside Global Institute can provide you with one of 2 intensive certification courses. You can be certified as a trauma-sensitive professional, which is a 50-hour online training experience. Or, for a deeper experience, you can become a Lakeside Global Institute certified trauma-competent professional through a live Zoom process that is 75 hours of well-researched and practically applied training. Lakeside Global Institute provides professionals with the highest level of training sophistication and integrity for you to be proficient in trauma-responsive care. You can learn more by going to lakesidetraining.org for more information. Lakeside, your resource for trauma-responsive care.
Welcome back to Creating Presence. Sandy, Sarah, and their guests will discuss strategies and innovative practices for restoring our collective social health.
Welcome back to Creating Presence. I'm Dr. Sandra Bloom, and I'm here with my co-host, Sarah Yanosy. We want to talk in this segment to some people representing a young and innovative company called Charlie Health. Charlie Health is providing online intensive outpatient mental health services to children and families in states really across the country, usually to areas where there really are very few options for care where the clients live.
So one of our guests is Dr. Caroline Finkel. She is one of the founders of the company. And I like to acknowledge that her doctorate is in social work. So she's a social worker just like me. Great to have you here. Welcome, Caroline.
Thank you so much for having me.
And our other guest is Dr. Eli Muir, who is a child psychiatrist. He is the medical director of Charlie Health, and is the founding medical director. So has been responsible for, well, the growth that you're going to hear about. So welcome, Eli.
Thank you for having me.
So Charlie Health is relatively new, and your model of care is really different from other types of providers. So tell us a little bit about what inspired you to create a fully online IOP model, intensive outpatient model, for those of you who aren't familiar with that term, and how you use trauma-informed practice.
Yeah, absolutely. I think that one of the things that I did throughout my doctorate in social work was I did a dissertation on the use of technology in a therapeutic setting. And what I did was I sat with 40 social workers and asked them about how it is that they would use technology in any type of therapy session. My hope through this was to design some type of an app that we could use to track different emotions and feelings and share that data back and forth, which in 2016 was like a kind of a different idea. Nowadays, we know that AI and measurement-based care and being able to share data back and forth is something that's happening. But back then, nobody really had portals and things like that. So I was like, okay, what if we were to just take this app? And I sat with these 40 social workers and I said, what do you think about technology in a therapeutic space? And they said, I hate FaceTime. And I was like, okay, no, we're actually not talking about FaceTime. They're like, I also hate Zoom. I'm like, actually, we're not talking about Zoom either. They're like, I hate virtual care. And the next, so, I had, I don't know, 5 focus groups, each with 8 people in it. Every single one had the same theme, which is that providers did not like virtual care, which the research shows us that prior to COVID, patients loved virtual care, providers not so much. And when you would ask them these, finally, I gave up. I was like, I guess I'm just writing a dissertation now about how providers don't like virtual care, which happens a lot, right, in your dissertation. And, basically, it's so funny because I look back and after COVID, the people who were the most vocal about how if I am not in person, I'm not going to be able to see their body language. I do Gestalt therapy. I do empty chair. Those people don't have an office. They have not had an office space since COVID. They were like, I had no idea that this could work as well as it could. So I was not a believer in this. And when my co-founder called me and said, I've been doing a lot of research and I've been thinking about this, and I think it could be really powerful and really incredible and provide access to people who really don't have it. I was like, that's a really cute idea, but it's never going to work. And so fast forward, COVID hit, and, just like what Maggie and Tim were talking about, having to switch a brick and mortar partial hospitalization intensive outpatient level of care to virtual in one day, in person March 23rd on Tuesday, virtual on the 24th. I'm crying myself to sleep the night before thinking I'm going to have to do major layoffs. And these are people who I begged to come work for me, who are my friends, who are my family. And I have to lay them off tomorrow because there's no way that 50 kids are going to jump onto a Zoom link. It's just not going to happen, especially with the way that my dissertation went. And we were wrong. We had higher participation. 100% of kids showed up that day. We had higher participation. We had better outcomes. The better outcomes, I think, has a lot to do with this idea, because we treated teens, that parent participation in treatment is the single largest indicator for positive outcomes. So what would happen is we would say, hey, Sandy, is mom around? Do you mind bringing mom in? And Sandy would be like, oh yeah, mom's in the next room. She's working from home. She's on her lunch break. And we would bring mom in and we would say, Mom, look, Sandy's been cutting herself. Like, there's some razors behind you. They're in the bureau. She told me that I could tell you need to get them out of her. Suddenly you're doing wraparound care, right? Like suddenly you're in the home with them. You're a social, it was magical. Whereas when you're in brick and mortar and you find out that a kid cut themselves, you're now calling mom at work. Mom has to leave work early. She has 3 other kids. She doesn't have a way to get there. It's 45 minutes. She's sitting in the waiting room. The access for parents to be involved in care was so important. So between that and seeing these outcomes, seeing the participation, and then something really cool happened to me, which, being a social worker, you want to help marginalized populations. You want to help people who, are really struggling and who don't have this access. And I didn't get that. I wasn't able to fulfill that part of me because I was in the suburbs of Philadelphia. And I also started one outside of DC and one outside of San Francisco. And these just felt like empty, and we had a client call into our admissions line that lived in Pennsylvania, the area between Philadelphia and Pittsburgh. And they said, I really want to come to Center for Families. And we said, okay. And if you remember back then during COVID, they waived deductibles. So they didn't have a max out of pocket. They waived the deductible and they were in treatment. This kid had never experienced high quality care, had never experienced flexible scheduling, right? I mean, they're in this rural area, they're in like the middle of a cornfield. They're living in a trailer. Like, they've never experienced multiple time a week care. They've either been to the ER and been in psychiatric unit, or they've gone to once a week counseling at the local community center, which was an hour away, which sometimes they could get to. So experiencing helping individuals from across the state was really powerful. So I went back to my co-founder who presented me with this idea, and I said, you know, we've got to do it. This is really magical stuff. We can get the parents involved. We can help kids that are in rural areas. We can, you know, scale infinitely. Like, as long as you can get enough therapists, you can scale at any amount that you want virtually, because it's the office space is not an issue. So yeah, we took patient one, September 1st, 2020. Over the last 3.5 years, we've treated over 25,000 patients. We're live right now in 30 states, and we're just incredibly lucky and grateful to everybody who decided to join this mission. I'm happy to talk about trauma-informed care, but I just went on and on and on. So
Well, that was
yeah.
great.
That's great.
But I'd like to hear Eli's version of what your experience has been parallel to Caroline and getting this thing all off the ground.
I mean, it was amazing to witness her convert to virtual, because I would have never thought she would do that. She's a person who loves to be around people and animals. So to see her going virtual, I was like, no way. And then me go virtual, please. I'm one of the most extroverted people on the planet, right? So I was a late converter to virtual. In the pandemic, I remember sitting at home, and when they were like, you actually might have to do care virtually from home. You can't go to the hospital. I thought, I'll go to the hospital. I'll risk getting COVID. I just can't be at home.
Yeah.
So to now be entirely virtual, you know, over 2 years into the company at Charlie Health is just shocking to me. And I think what drew me to Charlie Health was, number one, exactly what Caroline said about just the access that you could get people from all over. I am from a metropolitan area where there's a lot of hospitals and brick and mortar providers, but you know, I wanted to be able to reach people who are in rural areas far outside of the city, don't have access to a car to drive into urban centers where there's the big academic hospitals. So I think that access really drew me in. And then I think the second part that drew me in was just the opportunity to build a psychiatry team bottom up that's trauma informed, because I just heard over and over again how sometimes when kids' families were seeking treatment, it actually made them feel worse, or they felt more terrified, more alone, more restricted in many ways, right? Let's take you out of school, keep you in a medical bed until there's an inpatient unit, put you in an inpatient unit for 2 to 3 weeks. Now you've been out of school 4 weeks. Okay, go back to school. Maybe you have once a week therapy, but you have to drive there, so you now can't do your sports team. So it just like really took people out of that day-to-day of their life, and I think at times would lead to more isolation. So I think I wanted to make sure that psychiatry was not scary, and that we would be really trying to help kids where they are, you know.
I'm curious about how, especially based on what you just said, Eli, you were ready to go to the hospital and risk COVID because being isolated was not going to work for you. How do you create a sense of team and connection in that virtual landscape?
Well, with my team that we've built over the past couple years, it's really meeting frequently. You know, I meet with everyone one-on-one each week, and that I think helps, just having that cadence. And then we meet as a team and try and just run cases by each other, and also just be with one another virtually. I'm in New York City right now because we just had our first off-site where we flew in the team to our headquarters here and all bonded in person, which was pretty incredible and kind of a little odd to finally see people in person. But I think with clients, I think it's looking at their room. I think that's like the number one thing I do is I'm like, oh, I love those lights behind you. Oh, is that your cat? You know, tell me about them. You know, oh, why don't you bring your dog over and introduce me to them, you know? So I think that's how I do it with clients, and with the team, I think it's just meeting frequently and like reminding them that we are still together.
What have been the barriers that you guys have encountered? Because it's clear the barriers aren't coming from the clients, and you've been able to find clinicians who are willing to do the work. But what have been the real challenges that you've encountered trying to get this all up and running and off the ground?
I think that recruiting is really hard. I think that when you look at supply and demand across the country, we know that the amount of money that people get paid from the payers, and then the amount of money that they put into their education, and then the cost of living, it just doesn't match up. And I think that, it's hard to find individuals that wake up one day and say, I'm going to go to school for an extra 2 years. I'm going to take a test. And then after that 2 years, I'm going to take another test. And I'm going to be in, somewhere around 70K of debt. And I'm going to emotionally burn myself out every day listening to trauma stories. And I'm going to make, 58K a year. It's just it's hard, right? It's like it's teachers are it's very similar with teachers, right? And it's like these people that are in this industry. So, what we try and do at Charlie Health is have a really unique value proposition for the therapists that work for us. You get to work from home. We have great benefits. There's 3 different ways that you can engage with us. You could be W-2 full-time, W-2 part-time. You can be an independent contractor. We try really hard to treat them well, make them feel really a part of, have that camaraderie. So I think recruiting has definitely been a challenge. But we're getting there. What else is a problem with standing things up? I mean, I think one of the things is honestly like software and product development around things like scheduling, like being able to have a portal where a patient can go in and schedule their own sessions based on their session, like their schedule. Their sibling might have to show up, their mom's schedule, their dad's schedule. And then, when the therapist is available, and it has to be after school and those types of things. But we're very lucky to have a really good product team that is working incredibly hard to improve access.
We only have a
Tell
couple
us-
minutes left, but I'd really, before we go, I'd really like you to share some of what you're seeing in terms of outcomes with your clients, because I think that's so critically important. And I
Yeah.
think you have some data.
Yeah, absolutely. So, basically, I think that one of the most important parts of Charlie Health is collecting data, and having really good data infrastructure. And very early on, we partnered with the University of Pennsylvania, we're partnered with Yale, we're partnered with Florida State University. And, what we continue to do is publish. So we have 7 peer-reviewed articles that have been published. We just continue to see these declines. And, we see a 49% decline in PHQ-9, 49% in GAD-7, a 71% decrease in self-harm frequency, which is just incredible. And we see these things that stay, the same throughout, at 3 months, 6 months, not even 9 months post-discharge, which we're just so proud of. One of the other things that we're really happy about is keeping kids out of the emergency room. We know that emergency rooms are great for physical healthcare issues, horrible for mental health care issues, traumatic, just terrible. And so what we see at Charlie Health, typically when somebody leaves an IOP, they go back to a higher level of care at about 20 to 30%. How sad, like really sad that IOPs are just not effective at keeping kids out of the ED. At Charlie Health, it's 3.3%.
Congratulations.
Wow, that's great. Also, just can you clarify for people who might not be familiar with the instruments that you named, the anxiety measures and depression measures, what that means?
Absolutely. Yeah, absolutely. So the PHQ-9 is really around depression symptoms, 9 questions. GAD-7 is around generalized anxiety, 7 questions. We also have the WHO-5, 5 questions that looks at wellness and how you're doing. We have a bunch of others that, are alphabet soup, but those are just some of them. But we're happy to make sure, Sandy, wherever this goes, we just published our 2023 annual outcomes report, which has everything in there, even things that are not in the peer-reviewed articles that we wrote this past year, but will be coming up in 2024.
Yay, terrific. Congratulations.
We just heard from Drs. Caroline Finkel and Eli Muir. You can reach us at creatingpresence.net or voiceamerica.com. See you next week.